Good afternoon, everyone. My name is Ramon Solhkhah. I'm the chair of Psychiatry and Behavioral Health at the Hackensack Meridian School of Medicine. Certainly very glad that you're here attending this SAMHSA-sponsored conference today on the opioid crisis. I'll be wrapping things up for us with a look at the opioid use crisis in terms of both its current status as well as some evidence-based solutions. And we'll be talking a little bit about some of the solutions that we've got here at Hackensack Meridian Health and specifically Jersey Shore University Medical Center. So I always like to start with a little bit of a cartoon before we get too serious here. And clearly part of the situation that we're in with the opioid crisis is related to the pain epidemic. And you can see here, any pain today not caused by the government, greedy corporations, annoying celebrities, or society in general. And certainly the society in general part right now seems to be particularly painful, but hopefully we're all going to get through all of this. So here's my disclosure. I'm a consultant for a few pharmaceutical companies and also have funding through a variety of different sources here for some of the research that I've done, none of which I don't think will be particularly relevant, but we'll be talking about some off-label uses of medications towards the end. My other disclosure is that I'm an old white guy with gray hair and grew up during the 70s and 80s with former First Lady Nancy Reagan and her attempt at tackling the drug problem by just say no. And we've modified that a little bit now to just say something, really focusing on educating parents, teachers, loved ones to really talk about this and make sure that we're all addressing this situation. So here's what we'll try and accomplish in our time today. Briefly review the history of opioid use in human civilization, gain an understanding of why there is an opioid problem in the US and particularly here in New Jersey, appreciate the impact of appropriately identifying, treating opioid use disorders in the patients we serve, understand various treatment options for opioid use disorder, and we'll wrap up with describing what Hackensack Meridian Health and Jersey Shore University Medical Center are doing to fight this epidemic. So here's our outline. Going to the heart of it, right? Why is there an opioid problem? In part because the opioids are a cornerstone of pain management, and they're really wonderful pain suppressing and pain management medications. But the crux of the problem is that they also have mood altering properties. And so, if you broke your leg, right, you'd want opioids, but it does come at a price, and particularly for those prone to substance use disorders. And part of it, and highlighting that piece is the pharmaceutical companies have really conditioned us now to be focused on pain medication and treating pain. And we all know what's happened with Purdue Pharmaceuticals and their settlements in terms of how they were marketing these medications. And that certainly has contributed to the problem. And then unfortunately, you can't turn on the TV or pick up the National Enquirer without seeing some aspect of someone famous, dealing with a substance use issue, whether that be someone like Prince or actors, going back to Amy Winehouse and the others here. It's certainly something that our youth and young adults are exposed to in terms of, well, everyone's doing it, look at the famous people doing it, and that certainly contributes to part of the problem as well. And then particularly here in New Jersey, prior to COVID, we knew that there were 3 people a day dying in New Jersey due to an overdose. That certainly, if you think about that, it's really, mind-blowing to think that 3 people every day, right? That's essentially an airplane filled with people dying every year due to opioid epidemics just in New Jersey alone. And, not quite getting the same sort of press that the Boeing company did when they had problems with their airplanes, right? So for us here in New Jersey, what are some of the issues? Well, we're at the crossroads of the ports of the East Coast. So between New York City, Newark, Philly, there's a lot of ports of entry. According to the DEA, they feel that on various testing that the heroin here in New Jersey is the highest purity heroin and essentially the purest form of it coming into the US. We know that prescription pain medications have had a consequence here as well, and particularly related to that bottom point, in terms of Superstorm Sandy. So people here in New Jersey were injured. They were doing, rehab on their houses, and they'd fall off the ladder. And then, it would tie back into this prescription pain issue where physicians and primary care docs would be prescribing it, and then leading to this sort of never-ending cycle. So thinking back in terms of human history, the ancient Sumerians and Egyptians wrote about the poppy plant, which opioids are derived from, probably started in the Eastern Balkans region of Europe and then moved into Egypt and into Asia Minor. The ancient Sumerians referred to it as the joy plant, Gil, and certainly some understanding of the pharmacologic properties there. And then going into the early 1800s with the discovery of morphine and heroin in the late 1800s. And then, we sort of get to the point in the early 1900s where you can see here Bayer Pharmaceutical advertising for heroin as a cheap relief of coughs. That you can see that it made its way into popular culture and really created a problem at that point. And the Harrison Act was passed in 1914, which basically prohibits physicians from knowingly prescribing opioids to patients with opioid use disorders. So it really creates a situation where how do we treat that and to try and limit it, but it has this unintended consequences, which we'll talk about in a minute. So then we had the discovery of methadone just prior to World War II. I apologize if that's cut off. And then the discovery of Narcotics Anonymous, which took the principles of Alcoholics Anonymous and used it in the treatment of opioid use disorders. And most recently, the Drug Addiction Treatment Act data in 2000, which helped allow us to use buprenorphine, one of the medications that you've heard about today. So what is an opioid? Opioids are classes of drugs that act on the body's opioid receptors, also known as narcotics. And there are opiates, which are naturally occurring derivatives of the poppy plant, and then opioids, which includes the synthetic formulations. And you'll hear me, I've already caught myself a couple times using them interchangeably, which most of us do. So just to be aware of that broad class. In terms of the opioid receptors in the body, we've discovered at least 17 receptors the last time I looked. There are 3 classic receptors that we really focus on: the mu receptor, named for morphine, which is really responsible for the analgesic products of the opioids. Then the primary action site of all opioids is on the mu, and then it can have some other consequences on other receptors. It's distributed in the CNS and GI systems. So as you think of both positive and negative effects, that's certainly explained partially by its distribution. And it's really the mu receptor that's responsible for most of the issues with abuse and dependence. There's also the kappa and the delta more focused on endogenous peptides, and the kappa being focused on analgesia, as well as some of the endocrine issues that come up with its use. So in terms of the medical uses of opioids, primarily used for analgesia, as we've talked about, but certainly cough suppression and antitussive effects, treatment of severe diarrhea, and then maintenance treatment of opioid dependence, where I, as an addiction psychiatrist, have a lot of work in terms of opioids is really in prescribing in that situation, whether we're talking about methadone or the combination of buprenorphine and naloxone, which again, we'll talk about a little bit later. In terms of prescription opioid abuse by physicians, clearly part of what we worry about is the physician dated and out of knowledge, which all of you who are physicians in the audience today are attending here, so clearly not dated. Any one of us can obviously be duped and misled in a particular situation, but where it really becomes a problem is when it's ongoing. Is the physician disabled in some way or dishonest, and certainly human vices can apply to physicians as well. Clearly, all the final common pathways, even for the opioids, leads to dopamine in the nucleus accumbens and the activation of the reward pathway. And what ends up happening is that the opioid system overtakes the normal dopamine system in terms of the pleasure principle. So those things that are normally pleasurable to us, such as food, water, sex here, but also, over time, things that we enjoy, hobbies, reading, watching TV with our family or friends, all of those sorts of things that have that pleasurable impact over time, the opioid system wipes those out and really doesn't allow us to enjoy that pleasure in the same way because it's so overridden by the opioid system, right? And here you have the nucleus accumbens, which connects to the VTA, the ventral tegmental area. And that's really that pathway that we're focused on. For part of my career, I taught at St. Luke's Roosevelt Hospital, which is now part of Mount Sinai Medical Center, but on the campus of Columbia University. You go into the bookstores or any of the bookstores around the campus, and you'd have these postcards, you know, sort of pro-marijuana, pro-dope, and what have you. And so even going back to you know, some of the older comic books where they talk about, you know, these sort of impacts, right? So we'll talk about some of the definitions here in terms of criteria. So substance use, opioid use is use at least once, defined clearly with a time period. So are we talking about lifetime use? Are we talking about use in the past 30 days, use in the past year? So you usually have a time qualifier there. Misuse is where we're not just using it recreationally, but there's really beginning to be a pattern of use, and some of the more negative consequences are beginning to appear. And then in the old nomenclature, we had abuse and dependence. Abuse being the pattern of misuse with impairment and or consequences, and then dependence being that what we would typically call addiction with associated impairment, inability to control use, physiologic symptoms such as tolerance and withdrawal, right? Tolerance being that the same amount of the drug no longer causes the increasing effects, and so you need to use more and more in order to get that effect. And then withdrawal, which is when you take away the substance, or if you're administered an antagonist, you're going to have a very predictable set of symptoms that occur, which are the result of the substance, right? And we've lumped together abuse and dependence, and I'll talk about that in a second. But you know, the way I used to think about it was abuse tends to be more external consequences. So getting into fights with your loved one, perhaps getting pulled over by the police for intoxicated driving. So the consequences are out in the world with other people, not necessarily internal, although they can have consequences for ourselves. But for dependence, it's much more the internal consequences, whether those are medical complications, psychological complications, the tolerance and withdrawal, which we're experiencing inside our bodies. You know, that's really the differential between those two. And so I'm not going to go through these slides in detail. I chose to keep them in just to remind everyone that we started off in the DSM-4, the Diagnostic and Statistical Manual, 4th edition, really looking at abuse and dependence as being two distinct disorders. So you can see here, maladaptive pattern manifested by at least one of these symptoms over a 12-month period. And again, you can see external symptoms in terms of substance use in situations in which it's physically hazardous, legal problems, you know, not being able to do the things you need to do. Okay? And then there's opioid dependence, which you need to have 3 of these symptoms for the same 12-month period. Again, starting off with tolerance and withdrawal, which I mentioned previously, and then going on into these other symptoms. So needing to take more substances over a longer period of time than was intended. So I thought I was just going to use on Friday night. Instead, I end up using the whole weekend. Persistent desire to cut down, and you know, spending time prepping for the use, recovering from the intoxicating effects, and you know, you could see here the criteria modifiers. And in the DSM-5, the latest version, the Diagnostic and Statistical Manual, the 5th edition, we really got rid of abuse and dependence, and instead now talk about substance use disorder. So opioid use disorder, alcohol use disorder, marijuana use disorder, because we wanted to collapse the abuse and dependence, because you know, people are obviously over different points of their lives, could be a little bit fluid across those diagnostic criteria. And there's the concept of diagnostic orphan. So you saw you had to have one criteria in the abuse, but what if you're not having any external consequences, using a lot of opioids, using a lot of heroin, but you know, you're smart, you're able to do work and not have consequences at work, your loved ones maybe don't notice what's going on, you know, and then that's an issue. And then what if you only met 2 of those criteria for substance use dependence, for substance dependence, and didn't have that 3rd criteria? Technically, you could not meet criteria. And so we call those diagnostic orphans. So this is a way for us to understand that schema and consolidate them. So now we have in the DSM-5 an opioid use disorder, which essentially combines all of these. And you need to have at least 2 of the criteria. And it literally is just a combination of the 2 criteria. But I'll jump here to the back end. And now what we do is we rank the substance use disorders being mild, moderate, or severe. And if you think of other medical conditions like hypertension or diabetes, that's how we consider those as well, right? That they are based on the severity of the illness. So this is in line with that. And then there are some modifiers here, which we'll not spend some time. So I've mentioned a couple times addiction and dependence of some of the other speakers today. And really, you know, dependence is that physiologic state that occurs related to the substance, right? So we can become dependent on, you know, depending on how you want it to define it, right? You're dependent on insulin if you're diabetic. So you need it and it functions. Addiction tends to be that more behavioral piece where we're focused instead upon, you know, the dishonesty, some of the, you know, sort of distrust that a family may have. And, you know, the way I think about this is, you know, earlier today, as many of you were getting ready for the day or when you were first joining the symposium, you may have had a cup of coffee and needed to have that cup of coffee, right? If you don't have coffee, you're going to become angry. You could have headaches or physical symptoms of withdrawal if you don't have that. But very few of you were going to rob a bank in order to go to Starbucks, right? So the behavioral pieces of it are not there, even though the caffeine addiction may be, or the caffeine dependence, excuse me, may be there. So physical dependence and addiction are certainly 2 separate constructs, with the addiction being more focused on the behavioral piece. So thinking of opioid intoxication, there are signs and symptoms that we can do to predict it. So it tends to be, you know, sort of sedating, right? So you can see the sedation, the hypotension, the lower heart rate, a calmness, analgesia. So that tends to be in the early stages of the intoxication. And again, there are defined criteria, which any of you could look up. I'm not going to go over in detail here, but just to be aware of. And then there are also predictable symptoms of withdrawal that can occur, and associated here, the yawning, the fever, the you know, tearing eyes, runny nose, the pupillary dilation, so your eyes get bigger, you know, the piloerection, so that the hair on your arms and legs stands up, so really becomes problematic, and we'll talk about that in a little bit. Right, so another cartoon here. What's the strongest over-the-counter painkiller you got? And it's a, you know, a hammer to the head. You know, as we talk here, most of you know about Hackensack Meridian Health, but for those of you who don't, right, a large health system here in New Jersey, you know, we're focused on the behavioral health, which is this lime green color here, and the services that we have, and we'll be talking about the services that we offer here at Hackensack Meridian Health in a minute. So I also like this ad from Bayer, again, not only for aspirin and heroin, but what I like about this is you could send for samples for the heroin, right? So a very different day back then. All right. So given all of these constructs, you know, can we do nothing about it, put our heads in the sand and ignore it? I hope not. I hope we want to all try and do something to try and change that problem. So we'll focus into treatment. So certainly here without medications, right, there's the cold turkey approach and the sense of kicking the habit. And you can see here this plucked turkey or plucked chicken that, you know, has that piloerection, right? So that's where people get the expression cold turkey, and kicking the habit goes along with some muscle cramps and muscle twitches that can oftentimes happen during the withdrawal. So that's where the expression kicking the habit came from. So you can impress your friends this weekend when you're at a party with your trivia knowledge. And so we can treat the opioid withdrawal without any medications, with medications, which I would certainly advocate. So there's methadone, buprenorphine, other medications, which we'll talk about. There's a class of treatment which is called rapid opioid detox, which is no longer available, but we'll talk about just to give a sense of where we've been. And then, of course, the psychosocial treatments. In thinking of treatment goals for our patients, we want to be thinking both acute and longer term in terms of what we're going to be addressing. So certainly in the acute phase, right, we want to address safety and risk of overdose. address the potential for withdrawal, address the risk for relapse. And then, should we be taking a harm reduction approach in a medical sense, not in a political sense, focused on abstinence as our ultimate goal for drug treatment? And, I usually take a harm reduction approach personally in terms of my initial engagement, while abstinence may be my long-term goal with the patients in terms of their use and abstinence from that substance. In the initial phases, it's really about reducing risk and reducing safety risk in particular. So how do we minimize the risk for overdose and death? Certainly we have to address any physical or psychiatric comorbidities that are going on. And oftentimes that's part of what happens is that, the substance abuse provider says, well, I won't deal with the psychiatric piece. The psychiatric provider says, well, I can't deal with the medical piece. And so everyone ends up playing hot potato instead of trying to address all of these syndromes in a very comprehensive way. Right? And ultimately, we want to move towards maintenance treatment that's going to achieve a stable dose of replacement that will suppress the withdrawal symptoms, both physically and psychologically, decrease that craving for the substance, which is more psychological, and blocking the effect of any illicit opioids so that if there is a slip, it doesn't become a full-blown relapse. And then thinking about longer-term rehabilitation and recovery. Although for many of our patients, it's really not rehabilitation, it's habilitation, because we're teaching them the skills that they may not have learned during earlier parts of their life. So we'll take these in order. So the cold turkey approach allows for the natural progression of the signs and symptoms of opioid withdrawal without the use of medications. Symptoms generally begin about 8 to 12 hours after the last heroin use or any opioid use. Patient's eyes begin to tear, starts to experience flu-like symptoms, sneezing, depression, muscle cramps, nausea, vomiting, diarrhea. So if you've ever seen the movie Trainspotting, which if we had a little bit longer time, I would have shown a clip from, really highlights a lot of these symptoms. Typically increase in severity over 2 to 3 days, and for most people within 3 or 4 days, certainly no longer than 5 to 7 days, the symptoms have withdrawn. It's, as I said, no longer than a week or 10 days. I told you about the cold turkey and the kick the habit piece here, right? So the muscle spasms and the piloerection. And our patients will oftentimes report that this is the worst that they've ever felt, that they're dying. If you're working in a hospital, right, these are the patients who are coming to the nursing station and screaming and quite carrying on. Because it is physically uncomfortable, don't get me wrong, but physiologically, the way that the opioid withdrawal works, you can't actually die from the withdrawal, right? As contrasted with alcohol withdrawal, which you can actually die from. So particularly an issue where we have to be mindful in patients with significant medical comorbidity. So patients with HIV or AIDS, patients with cardiac issues. So if they had endocarditis or currently have endocarditis, that may put them at unique risk where the withdrawal we want to be thinking of in a slightly different way. And, for insurance companies, right, it's the cheapest and easiest form of detox, unless it's you or your loved one, right? We wouldn't want our families to go through this. We wouldn't want to go through this. So methadone has came along as sort of the first real systematic approach to trying to manage long-term withdrawal and dependence. It's a highly regulated substance, generally has to be prescribed by a physician in a SAMHSA certified methadone clinic. Can be used either for short-term detox or for longer-term maintenance. It's a full mu agonist, so I tend to think of the opioid receptors, right, as being a light switch. So you're either off or you're on. The mu receptors turn it on, and so methadone is doing similar things to what the heroin is doing, just without some of the more severe consequences. And the 40 to 60 milligram dosing here is generally sufficient to block symptoms of withdrawal. Oftentimes need patients with higher doses of the methadone in order to prevent the psychological withdrawal and psychological consequences. And I'm a child psychiatrist as well, and so focused on adolescents and treating adolescents. Methadone allows certain unique set of problems that you have to deal with parental notification, and have to have documented failed treatments, which again, I think of the double standard, right? If we were talking about diabetes, you wouldn't have to fail treatment multiple times before you could be referred for that ultimately life-saving treatment, but that is the case with methadone here. LAAM, levomethadyl acetate, is no longer available. Again, just mention it because it was seen as a longer-term treatment. From it, people think that LAAM stands for like long-acting methadone, which it does not, levomethadyl acetate. But it is withdrawn in part because it had a very severe cardiac potential and causing torsades de pointes, a very significant arrhythmia. So it was pulled from the market. And then in 2000, we had the introduction of Suboxone and Subutex into the substance use disorder treatment market. They'd been available, buprenorphine had been available previous to that as a pain medication, but it was studied and approved for treatment of substance use disorders. And so what's the difference between Subutex and Suboxone? Subutex is the pure form of buprenorphine, whereas Suboxone is buprenorphine and naloxone, which is an opioid antagonist, in a 4-to-1 ratio. Why was it created this way? Because that was the only way the DEA would sign off on the release of buprenorphine into the medical market and being able to be prescribed and people having take-home doses. So the naloxone is thought to be there to prevent abuse of the prescription medication. And if you take the pill or the sublingual formulation the way that you're supposed to, you get the pure buprenorphine effects, none of the naloxone. But if you crush it, snort it, sniff it, try and inject it, then the naloxone effect comes out and it becomes more of an antagonistic effect rather than the buprenorphine effect. So buprenorphine is a partial mu agonist. So remember I told you earlier that the opioid receptor is like a light switch, and buprenorphine is a dimmer switch. So it lets you come in and fine tune the receptor levels a little bit. So at the lower doses, which is where we're prescribing it, it's not an agonist. It's got slight agonist effects there. So it's only giving some of the prevention of the negative side effects and not so much of the reinforcing positive effects. It's been, as I said, available as a treatment for pain for a while, and was approved in Europe actually for a while as well. So the buprenorphine dosing, originally we thought it was in the 8 to 12 milligram range. Now we realize it's at least 12 to 16 milligrams for most patients in terms of maintenance, really shown to be safe and effective in promoting treatment retention and reducing illicit opioid use among opioid dependent adults and teens as well. And there's a lot of safety data since it's been used as a pain medication. There's studies in pediatrics where kids as young as 9 months of age have been given this medication safely. So it's got a nice safety and tolerability profile that we're well comfortable with. So switching gears here a little bit, we can treat the symptoms of the opioid withdrawal. So we have Clonidine, which is going to treat the sympathetic, nervous hyperactivity during that opioid withdrawal. So it alleviates a lot of the physical symptoms of the withdrawal, but really doesn't do much to alleviate the psychological impact. And then we have Naltrexone, which is an opioid antagonist. The way I think of naltrexone, has a very high affinity for the opioid receptor, and it's really like saran wrap. It will cover that receptor and stay there pretty tightly, so that if someone takes heroin, if someone takes buprenorphine, other opioids, the affinity of the receptor for naltrexone is so high that those other receptors those other substances just bounce off the receptor. And so if someone does use an opioid while they're on naltrexone, the opioid, that heroin or the OxyContin or whatever else it is, can't bind in the receptor. So what is a slip doesn't actually become a relapse because they're protected from the physiologic effects. So we'll talk about rapid opioid detox here for a second. So it's not really a great picture, but it was the only one I could find. So I've used it a lot. So it was here in New Jersey, actually, where it was started. And, it was basically you go into an ambulatory surgery center, same day, sort of setting, and get intubated, put under general anesthesia, and then given high doses of naltrexone, and it essentially scrubs your receptors clean. And so you wake up 6-8 hours later and you've completely slid past withdrawal, and you wake up completely sober. Two problems with that. One is that patients, when they walk out of that surgery center or doctor's office, whatever, they're completely sober and they're naive to substances at that point, essentially. So they could go out, use substances, and I used to use 3 bags and go out and use that same amount, and it could literally overdose and kill them. And second of all, even in 2021, we know that anesthesia has some side effects and some mortality. And so you take a disease in opioid withdrawal that has no mortality, and then put them at risk with anesthesia. So the state of New Jersey actually shut that down and was the first state to shut them down, and it's now illegal across the rest of the US. And then lastly, we have the psychosocial treatments. So thinking about cognitive behavioral therapy or behavioral therapy and things like contingency management, which we have a project that we're looking at with Dynamic Care and Horizon Blue Cross Blue Shield looking at that. Contingency management is a wonderful intervention. The problem is it's a little bit expensive, and particularly on the front end. And so people oftentimes balk at paying for it. But if you look at the savings that down the road in terms of emergency room visits, severe consequences, it really is a relatively cheap proposition. And then we have psychodynamic and interpersonal psychosocial treatments and psychotherapy. Generally speaking, most of us don't do that in patients who've got less than a year of sobriety. The reason being that the more psychodynamic approaches and psychoanalytic approaches, right, part of what you're trying to do is look at conflict, underlying conflict, right, and interpersonal relationships. And if you do that with someone who's early in their recovery, it can be very psychologically upsetting, as we all might imagine. And so the patient could go back to old coping strategies, including substance use. So we want to make sure that they've got a good solid year of sobriety before they are able to participate in more psychodynamic approaches. There's certainly group and family therapy, such as network therapy. The self-help fellowships play an important role here. Both Narcotics Anonymous for the patient and Nar-Anon for the family members can be really important interventions. And then lastly, therapeutic communities such as Detox Village or Samaritan Village. We'll talk about that in a second. So Narcotics Anonymous, Jimmy K is the founder here, and just as Bill W was in Alcoholics Anonymous. And it's a self-help fellowship based on the 12-step principles of Alcoholics Anonymous. Currently about 60,000 meetings, 63,000 meetings running in 134 countries worldwide. As I said, founded in 1953. If any of you attending today have never been to an AA or NA meeting, I would encourage you to attend. I think it's critically important for anyone to attend and be aware of, and typically recommend our students or residents attend a minimum of 3 meetings and 3 different types of meetings to get a sense of the different flavors and sort of styles of how these meetings run. The meetings very much are dependent upon their location, the people who run them, and can have very different sort of environments. Open meeting is open to anyone. So you can go in, identify yourself as a healthcare provider, as a concerned loved one, just whatever it is. And a closed meeting is limited to those who have a substance use disorder and are attempting to become sober. Here are the 12 steps. Again, I'm not going to read them in detail. I would encourage you all to be at least a little bit familiar with them, where most of us are familiar with the first step, right? Admitting we were powerless over our addiction, that our lives had become unmanageable. Second, we came to believe that a power greater than ourselves could restore us to sanity. For some people, they get a little hung up on some of the what they think are religious overtones, but are really more spirituality focused. Even though it does have the word God here, it's very clear God as we understood him. So I've had, patients and worked with patients where, it could be their art, their poetry, their spirituality. It could be their religion if that's important to them. But, it's got a wide variety of meanings here. And we try and not be judgmental as healthcare providers, and instead let the patient define what that is. And then there are also the 12 traditions. Again, you can see them here. Our common welfare comes first, and number 3 here is the one that I always point out to people. The only requirement for membership in NA is a desire to stop using. So it's not that you are sober, it's not that you have stopped using, it's just that desire. And so that's a very important tenet for membership, and one to be repeated. And so as a healthcare provider, there is such a thing as 12-step facilitation, so that if a patient is in treatment for opioid use disorder in a self-help fellowship, you don't have to be an expert on it. And the way that I learned most was by asking my patients. So I encourage you all to do similarly. So you can ask them about how many meetings are they attending. There's a philosophy of 90 meetings in 90 days, so that they should be going to a meeting a day in their first 90 days of recovery. So are they at that stage of their treatment and engagement with NA? Do they have a home group, which is that one group a week that they really sort of anchor themselves to? Do they have a sponsor, someone who's been in the program longer than them and is working to help them and support them? And what step are they working on? What's important on them? How far along the pathway have they gone? And again, you can ask those questions and learn from your patients. So therapeutic communities, which I was talking about before. So we've got, Daytop Village and Phoenix House being the 2 best examples locally here in the East Coast. And the interesting philosophy for therapeutic communities are that the drugs aren't the problem, they're the symptom of the problem, right? You're the problem. And so if you're the problem, right, then just achieving sobriety from the substance won't change that. And so it goes back again to that notion of rehabilitation or even habilitation to really teach patients how to cope in the world and how to deal with things differently. It's really interesting. The scientific research on therapeutic communities isn't completely clear on what the secret sauce is and what are the key components that you must have in order to achieve success with therapeutic communities, although research has shown that they are clearly effective. So these are some of the components of it that I've got here on this slide. Again, in the interest of time, not going to go over them in detail. For those of you who are interested, you can certainly look a little bit more into it, right? But it's really essentially boils down to using positive peer pressure. So using the components of a community to help change behavior and change coping strategies, right? So what is Jersey Shore University Medical Center doing, and what is the Hackensack Meridian Health doing? So this is a picture of myself and my colleague, Dr. Joe Miller, from when the Hope Tower here, the Healing Outpatient Experience Tower, which is our multi-story physician pavilion. We were able to receive a philanthropic gift from the Paracone family to honor their son, Christopher, who passed away due to his addiction illness. And they've turned that gift into a way for us to help not only treat patients and provide the services, but really broadly to focus on education activities among physicians and healthcare providers, including events like today. So what else do we do across the many campuses of Hackensack Meridian Health? We do Narcan replacement for first responders, so that if at 3 o'clock in the morning an ambulance or a police responder utilizes their Narcan kit, we replace that for them through the emergency room and from our pharmacies. We have partnerships with the Opioid Overdose Recovery Program, ORP, which is a partnership with Robert Wood Johnson Barnabas in Ocean and Monmouth County in particular. We've just started a pilot project with CFC Loud and Clear to provide our own peer recovery specialists in our emergency rooms at Jersey Shore University Medical Center, Hackensack University Medical Center, and potentially JFK Medical Center. That will then expand network-wide if that model is successful. And then we also have multiple attempts around buprenorphine training, including the SAMHSA grant that you've heard about, and providing X waiver to the physicians. Although with the at the end of the Trump administration, and it was initially put on pause, and then the Biden administration continued it, some of the training requirements for that X waiver have gone away to try and encourage physicians to really utilize buprenorphine, particularly in the crisis that we're in. Up until COVID, we had been really trending very positively around intervention here. But with COVID, we've seen now last year was our worst year ever. In terms of overdose deaths, the the average life expectancy of Americans went down by 1.5 years last year. And that's a combination of COVID as well as the overdose deaths. So it's definitely not a good direction for our country to be moving in. And then we have our behavioral health services and our addiction recovery service, ARS. And we have 3 board certified addiction psychiatrists. We have a cadre of addiction medicine specialists now. We've started an addiction medicine fellowship at Jersey Shore University Medical Center to really try and change the dynamics in terms of healthcare delivery here in New Jersey and make sure that we're addressing these situations. And here's a little bit more detail about the Addiction Medicine Fellowship, which is really just to remind people that one of the key components of this fellowship is that it takes in fellows who've completed residencies in multiple specialties. So whether that's emergency medicine, anesthesia, psychiatry, family medicine, it's able to participate. So if any of you are completing a residency and interested in it, you can see my email address sort of there in the blue. Please email me and happy to connect you to information about our Addiction Medicine Fellowship. So our conclusions, not only at the end of my talk, but at the end of our symposium here today, right? Drugs are bad. I wish it was that simple that we could just all agree on that. But clearly, there are treatment interventions that work, and treatment works. And I think that is really the most important thing you can take away from the symposium today, is that there are interventions that are evidence-based that really work and work well. Stigma is still an issue that we continue to address across healthcare systems, not just our own, but really nationally to deal with. But I think it's really critical. And this last slide I'll show you is social service agency in the UK, United Kingdom, called Barnardo's. And they had an advertising campaign that was focused on really reminding us, right, that, the print here isn't very good, so I apologize. But the principle in the picture are pretty powerful in that reminding us that no one starts off wanting to use substances. No one wants to become dependent on substances. We all start off with our dreams and our desires, and things happen along the way that derail us. And whether that's a genetic vulnerability, whether that's a psychological or a physical issue that gets in our way. And so really want to make sure that we're thinking back and being as compassionate as we can. And this is not a choice, and really focused on instead a disease that we want to try and impact as significantly and as powerfully as we can. And so with that, I will end my presentation, and certainly thank you all for your attention today and your focus on this important topic that impacts, again, not just New Jersey, but really the whole country. And I wish you all a good day, and thank you again for your attention.